Have you ever wondered what's really going on inside your brain when an antidepressant starts to work? It's not as simple as just flipping a switch. Today, we're going to take a guided tour and unravel the amazing science behind these medications, from their pretty accidental discoveries all the way to the super precise tools we have today. So, to really get a handle on these treatments, we're going to follow their story. We'll kick things off with the core problem: what's happening in a brain experiencing depression? Then we'll tackle a huge question about why these drugs take so long to work. After that, we'll trace their evolution from what were basically blunt instruments to the highly targeted medications we use now. Let's get into it. Okay, let's dive right in, because to really understand the solution, you've got to understand the problem first. So, what is actually going on in the brain when someone is dealing with depression? Right off the bat, we have to be clear. Depression is so much more than just a bad mood. Clinically, it's defined by this persistent loss of interest, even in things you used to absolutely love. And this isn't just in your head. It can show up as real physical symptoms. For a long, long time, the biology behind depression was a total mystery. And then this groundbreaking idea came along: the monoamine hypothesis. Now, it sounds really complex, I know, but the core concept is pretty simple. What if depression is linked to a shortage of key chemical messengers in the brain? The main players in this story are these three chemicals, which are a type of brain messenger called a neurotransmitter. And you've probably heard of them: serotonin, which helps regulate our mood and emotions; norepinephrine, which is all about alertness and energy; and of course, dopamine, which is tied to feelings of pleasure and motivation. So the theory goes like this: when the levels of these messengers drop, the signals between your brain cells, your neurons, they get weaker. It's like having a bad cell phone connection. And this disruption in communication can then lead to all the symptoms we associate with depression. So the goal of most antidepressants, it's to fix this imbalance. Now, this brings us to one of the most common and frankly confusing questions people have about these medications. If they're fixing the brain's chemistry, why on earth don't they work instantly? It's such a great question, right? The medication starts boosting those neurotransmitter levels almost immediately, but people often don't feel any better for several weeks. So what is going on during that waiting game? Well, the answer is that the immediate chemical boost isn't actually the main event. It's just the trigger. It's the first domino that starts a much slower, much more profound process of adaptation inside the brain. So here's what's really happening in that 2 to 4 week window. First, the drug immediately boosts the chemical messengers. But the brain is incredibly smart. It notices this sudden flood, and it starts to adapt. Think of it like someone shouting at you. At first, it's overwhelming, but after a while, you kind of start to tune it out. That's what the brain cells do. They actually reduce the number of ears or receptors that they have, becoming less sensitive. This recalibration, this downregulation, is what ultimately restores balance and relieves the symptoms. And that kind of major remodeling, well, it just takes time. Okay, with that whole mechanism in mind, let's go back in time to the very first breakthrough. Our story begins with the original pioneers of antidepressants, the tricyclics, or TCAs for short. TCAs were an absolute game changer. They work by blocking the recycling of both serotonin and norepinephrine, which means more of those messengers are left floating around. And they worked. They really did. But their action was super broad. It was kind of like using a sledgehammer when what you really needed was a tiny little screwdriver. And that sledgehammer approach was the real problem. Because TCAs weren't very precise, they ended up hitting all sorts of unintended targets all over the brain and body. This collateral damage is what caused all those notorious side effects. Hitting histamine receptors, that made patients really drowsy. Blocking others led to things like dry mouth, constipation, and dizziness. But by far, the most dangerous side effect was on the heart. In an overdose, these drugs could dangerously mess with the heart's electrical rhythm, which could absolutely be fatal. This major safety issue is the main reason why you almost never see TCAs used as a first-choice treatment anymore. The serious problems with TCAs really paved the way for a revolution in antidepressant science. Researchers started asking a really important question: could we design a drug that was much more selective? And the solution they came up with was just brilliant: selectivity. This led to the creation of SSRIs, which stands for selective serotonin reuptake inhibitors. So instead of that big sledgehammer, these were like a key designed for one specific lock. Their main job, and pretty much their only job, was to block the reuptake of just one neurotransmitter: serotonin. By avoiding all those other receptors, SSRIs have a much cleaner side effect profile. They generally don't cause that awful dry mouth or severe dizziness of TCAs. And, this is the crucial part, they are way safer in an overdose. This massive improvement in safety is what allowed depression treatment to move out of specialist psychiatrist offices and into the hands of primary care doctors. And that totally changed mental health care for millions of people. But hey, the evolution didn't stop there. The next step was the SNRIs, or serotonin norepinephrine reuptake inhibitors. Now, just like the old TCAs, they target both serotonin and norepinephrine. But, and this is the key, like the modern SSRIs, they do it with precision, avoiding all those other messy receptors. This dual action can be especially helpful for people whose depression also comes with things like chronic pain symptoms. So while the search for precision gave us SSRIs and SNRIs, other drugs work on completely different pathways. And one of the oldest classes, while it can be effective, comes with some really critical warnings. Okay, let's talk about the monoamine oxidase inhibitors, or MAOIs. These drugs work totally differently. Instead of blocking reuptake, they stop an enzyme in the brain that breaks down neurotransmitters. They can be very effective, but they have a really dangerous interaction with a compound called tyramine, and unfortunately, tyramine is found in a lot of delicious things like aged cheese and red wine. So if someone on an MAOI eats these tyramine-rich foods, it can trigger what's famously known as the cheese reaction. Basically, tyramine causes a massive release of norepinephrine, and since the MAOI is stopping it from being broken down, the whole system gets flooded. This leads to a sudden, incredibly dangerous spike in blood pressure called a hypertensive crisis, which can absolutely be fatal. And there's another really critical warning here: serotonin syndrome. This is what happens when serotonin levels get dangerously high. Now, it's a small risk with any single antidepressant, but it becomes a major, life-threatening danger when you combine drugs that increase serotonin, like mixing an MAOI with an SSRI. This is why it is absolutely vital that a doctor is carefully managing these medications. So when you put this all together, you can see this incredible story of scientific progress. It's really a journey from blunt instruments to incredibly precise tools. Our tour began with those powerful but messy TCAs. From there, science gave us the much safer, more selective SSRIs. That was then refined even further with the dual-action SNRIs. And the evolution just keeps going with a cool category we call atypicals. These are drugs that kind of break the mold entirely. A perfect example is bupropion, which targets dopamine and norepinephrine and has this unique side benefit of helping people quit smoking. This evolution is just amazing to see, but it leaves us with a really fascinating question for the future. We know depression isn't the same for every single person, so as our science gets even more sophisticated, will we move beyond these broad classes of drugs and into an era of truly personalized medicine, one that's tailored to the specific, unique neurochemistry of each person? You know, only time will tell.